my name's Mary Ryan and I'm the Program Lead for Team Effectiveness in the Capability and Culture Directorate at the CEC. And the webinar today is the second in a series of 4 webinars we're doing from the CEC as part of World Patient Safety Day, which is actually tomorrow. So at the end of this presentation, I'll give you the details for the upcoming sessions. But before I begin, I would like to acknowledge that I'm recording this webinar from the lands of the Gadigal people. I'm sitting in the eastern suburbs of Sydney right now. I also acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of this beautiful state that we're in. And this gorgeous piece of artwork that you can see on the screen was commissioned by the CEC. It's called Health Custodian, and it was created by Jasmine Sarin. And Jasmine is a proud Pumaliroi and Jerinja woman from New South Wales. So at the Clinical Excellence Commission, we're committed to continuous improvement in patient safety. We work in partnership with teams in hospitals, and we strive for safer care for every patient every time, which is, really a reason we're committed to promoting the activities of World Patient Safety Day. So just a few notes before we really kick off. As I mentioned, this session will be recorded. So it'd be great if you could mute your device or headphones to minimise any background noise and echoes. Please use the chat option to send through any questions or comments. I can't actually see the chat option, but I've got a few Brains Trust in there who will be keeping an eye on it. And I'm going to take a pause twice during the presentation and check in just to see if any questions or comments. We welcome any comments that you might have from your experience. And there'll also be time at the end of the presentation. We really hope you enjoy this session, and I have the extreme privilege to have the option of being able to work from home and choose to work from home mostly at the moment. And apologies in advance if my work from home companions get a bit rowdy. Hopefully they won't. They're pretty quiet at the moment. There are a couple of old girls who you can see sitting down at the right-hand corner of the screen, which is pretty much what they look like right now. So hopefully they'll, if they do decide to interact, maybe just take the opportunity to have a pause and a breath and write something in the chat while I deal with them. So essentially you're going to hear the what, why and how of the safety fundamentals. So you'll be able to name the 8 CEC defined fundamentals. You'll be able to discuss at your next dinner party the background to the safety fundamentals for teams, and also describe your guests with the safety outcomes that can be achieved from carefully implemented safety fundamentals. And you'll also appreciate how the safety fundamentals for teams have stood up in a crisis and what additions have been made. So hopefully you'll walk away thinking, I need to know more about that, or I need to evaluate what we're doing, or I need to tell people about this, about one or all of the fundamentals, or I need to get in touch with the CEC and let them know we need more resources, or maybe they could adapt theirs this way. So just to let you know that the fundamentals aren't a static list. In 2017, there were 7 fundamentals for teams defined by the CEC, and this was following a review of the literature, wide consultation, and our own experiences of working with and in the clinical field. In 2019, the fundamentals were reviewed in line with what? Let's get people to mute their lines, please. Were reviewed in line with feedback to the in line with feedback to the CEC and further learnings from the clinical field. So 2 of the original fundamentals were replaced with 3 new ones. And we recognise that most of the 8 fundamentals were already in use across New South Wales Health, but with varying reports of effectiveness. So this presentation is going to briefly outline the evidence that inform the fundamentals, like where we plucked them from, and provide a brief introduction to each of the fundamentals. So emerging safety fundamentals, as I mentioned, developed during the pandemic crisis, will be described, and we'll show you where the resources are that you can apply and modify to your clinical area. So on this slide, you can see the list of the 8 fundamentals for teams as they are now. As I've mentioned, they've been revised once, and we'll continue to work with teams who are doing the hands-on care to maintain currency of the fundamentals and adapt them as the evidence updates and in response to the experiences and demands of the clinical field. So the really beautiful tree image represents the 8 fundamentals as a solid root base or foundation. So when they're implemented effectively, so using a known and proven methodology, for example, quality improvement science methodology through testing and adapting using PDSA cycles, for example, they'll nourish and enhance those branches of safety culture, teamwork, person-centred care, staff experience, psychological safety, leadership, trust, and everything that goes with these concepts. So that they're designed to move teams towards high reliability. So a little bit about what they are and what they're not. So it really gives us, this gives a snapshot that they're an activity or a process which can change behaviours that impact safe and quality care. And when implemented and regularly evaluated, the changes can be demonstrated in improvements in staff and patient experience. Most are practical, and some require a short implementation time. So, for example, something like safety huddles, you could start testing for them next week with just a couple of committed, interested people on working on a small test site, and then adapt and change over time. Whereas something like leadership walkarounds will require more planning and more education. All of the safety fundamentals are measurable and adaptable, and they're not something necessarily aspirational like safety culture. They're meant to be practical and adaptable and usable. We didn't design them as a bundle or something that needs to be implemented sequentially or all at once. Apart from, safety huddles are now mandated through a work health and safety policy, but specifically, none of the fundamentals are really mandated in policy. So, which is why, one of the reasons that they were identified. So apart from the hands-on experience, what we've seen and what we've worked with, where else do we go to find out about best practice? So we took a broad and comprehensive view of the evidence to help inform the selection of the safety fundamentals. So as I mentioned, this evidence has been combined with experiences from our local field. And just to unpack this slide a little bit, when we look at the clinical microsystems, if you're not familiar with the work of the clinical microsystems, it arises from systems theory thinking. So they're found at the point of care where hands-on patient care is delivered within a context. They're often called the working hub of a larger organisation or hospital. So very briefly, microsystems are made up of clinical and non-clinical staff, as well as patients, their families, and carers. The people who make up clinical microsystems work towards a common goal, and they're part of a larger organisation. So for examples of clinical microsystems are an inpatient ward, could be surgical or medical, an emergency department, an outpatient clinic, or a community setting. They're all connected, with some having more natural associations than others, for example, delivery suite and postnatal units. And when there's a shift in one microsystem or one clinical unit, it will impact others. So you would know, for example, if there's a delay in somebody going down for surgery, that could delay a whole day, which could delay an outpatient clinic, which could delay discharges, which could delay transfers of care, which could impact the emergency, could impact an outpatient, impact a community, and most of all impact a patient, their family and carers. So microsystems are all come together to form, the larger kind of macrosystem hospital and our larger health system. Human factors was discussed yesterday in the presentation by Maria Crilly, which I'll give you, you can access at your leisure, and I'll give the link to that later today. But in her presentation on the Dirty Dozen, one of the things that she talked about was the impact of fatigue and stress on staff. Can I just remind people to please mute your mics? That'd be great. Team, there's no doubt that safety is dependent on functioning teams who teamwork. It's not enough to put together a group of people with the right skills. These people need to know how to work together. So they need to know when, where, and how to share their skills and knowledge, as well as take care of themselves. So healthcare is complex and dynamic, and it's not possible for a patient to receive safe, quality care from one health professional or one professional group. Therefore, working in a siloed or tribal way doesn't always protect for safe care, safe or quality care. And when we look at HROs, or high reliability organisations, these are organisations that can maintain a low record of harm, where when incidents occur can have catastrophic effects. So we want to know how they manage to keep such a low record of incidents. And it's really through, there are 5 characteristics which I won't go into, but it's through paying close attention to areas of risk and being proactive in risk mitigation. It's also around asking the right people the right questions. So those people who are right there delivering that hands-on work, who are right at the point of care delivery. So the way they work requires effective teamwork and attention to the right processes. In terms of mindfulness or mindful working, the evidence is strong on the use of mindfulness for increased awareness and focus. So these practices can be formal or informal. They train the mind to be present in whatever activity we're engaged in at that time. And then there's collective mindfulness, which refers to that shared awareness and attention of a team to emerging events within a context. And that's something that I'll talk about a bit later in we'll talk about safety huddles, for example. So collective mindfulness as a concept has been described relative to HROs, and there's a lot of interesting literature out there relating to that. Staff wellbeing, and I'll certainly talk more about that later, the quality of interprofessional teamwork has a direct correlation with clinician emotional exhaustion and their ability to engage. And this in turn impacts the experience of care for patients. And I'm going to talk about safety culture on the next slide, but I think it would come as no surprise that there are a lot of overlapping themes in all of the literature that I've sort of touched on here. And saturation of these themes is quickly reached when you start to delve into the evidence. So in terms of safety culture, what we observe, measure, experience is defined as the culture of a unit. So if you think about our understanding of clinical microsystems, the culture in one unit will contribute to and inform the culture of a larger organisation. That's often referred to as the way people go about their work, and others refer to it as the way people go about their work when no one's watching. So it forms, safety culture actually forms part of that overall culture, and places with a positive safety culture will exhibit a stable workforce, high engagement, minimal preventable harm, and they'll show that continuous learning and improvement mentality. So for example, in my previous position, so I didn't introduce that earlier, so I've worked at the CEC now for around 7 years. Before that, I worked as a clinical nurse consultant in women's cancer nursing. And I worked in my previous organisation for over 25 years. And on the whole, it was a really positive place to work, hence why I stayed there so long, and hence why they found it hard to, get rid of it. Not they tried to get rid of us, but why a lot of people didn't want to move on. It was a positive place, there was low turnover, but then there were times when the culture went on a bit of a dive and morale was low. There was high staff turnover, cliques were formed, more incidents were occurring. But with some shifts in people and processes, there's really great benefits in staying in places a long time because you get to see the highs and the lows. Until the time, some shifts in people and processes, and then, the time came that we were picked up, dusted off, and set back on track. So James Reason, and we refer a lot at the CC to the 5 elements of safety culture as described by James Reason. And in terms of an informed culture, it's around really knowing the data, collecting the data, sharing the data, and really interrogating the data. It's not just about collecting the data and ticking it off as we've done that this month, now let's go on to the next month. It's really knowing, sharing in the spirit of transparency, interrogating and understanding it. In a reporting culture, there's an environment where staff feel it's okay to speak up, regardless of their position, whether it's clinical or non-clinical. So, for example, where the catering lady might feel safe enough to come and tell the RN that, the patient, Maggie May in room 3, every time I take her tray away, she hasn't eaten anything, and I asked her why she's not eating, and she said she came here urgently from the country and she didn't pack her dentures, so she can't chew. And this is a woman who was admitted from a rural place to a city hospital for cancer treatment. And if the catering lady hadn't felt safe enough to come and speak up to staff, this is quite a traumatic experience for this patient. So, and that's a true story. So, regardless of who they are, everybody who has their eyes on the patient, including the patient and their family, needs to be able to have that opportunity to speak up. In terms of a learning culture, it's learning from error and also near misses, but also why things went so well or why they're going well. And I don't mean that in a cynical way. It's really investigating, thinking, well, how did that go so well? Is it because, oh yeah, actually, well, we had that new, Jamie, the new JMO, had just done a surgical term and knew more about that, to help us with this issue that we're having here, for example. And I think in terms of a flexible culture, that New South Wales Health has really proved its ability in terms of flexibility. And there's a couple of words that have really shone through in over the last 6 months or so that I keep hearing. One is unprecedented and the other is pivot. And I think New South Wales Health has really shown its gold stars in terms of the ability to be flexible and adapt in a time of high pressure. There also needs to be, a just culture or an environment of fairness. So I don't know if you're familiar with the work of Amy Edmondson, who coined, psychological safety. So a positive safety culture exists where there's an environment of trust and staff feel safe to speak up. And teams are always more effective when staff feel comfortable to admit that they've made a mistake, or that they don't know how to perform a task. I know as I've got older and more experienced, I find it much easier to say I don't know than I did when I was a first year or second year RM, which is a bit frightening. They share their knowledge and experience and learn from the knowledge and experience of others and feel that they have the space to question and to innovate and be creative and not just get stuck with traditional ways of doing things. So in this environment where people do feel safe to speak up, no matter their position in the hierarchy, staff and patient safety is enhanced. So we also recognise that psychological safety in teams takes time, consistency and trust to build and can be quickly dissolved if staff feel ridiculed or threatened. And this is really in line with World Patient Safety Day, which has a theme of health worker safety, a priority for patient safety. And we know, and we say this a lot, and it's something that we talk about in the work that we do, is that we recognise that we can't provide good patient care if our staff don't feel looked after. So the slogan is safety health workers, safe patients, and the call for action is to speak up for health worker safety. So I'm not sure if you're familiar with the research on the 3 waves of innovation. So this work was published a few years ago by Gafiri and colleagues. And the safety fundamentals for teams are consistent with the research on the 3 waves of innovation. So the first wave focused on the technical advances, so advances in surgical techniques such as laparoscopic surgery, robotic surgery, the novel, all the targeted therapies that are coming out now, focused training of staff. Whereas in the second wave of innovation, we moved towards standardisation, and along came our checklists and audit and reporting, as well as, a closer look at our data and starting to understand, collect and look at our data. And these advances certainly reduced morbidity and mortality, but the improvements came at a risk of plateauing. So the third wave kind of goes beyond the technical and structural innovations and focuses now on embracing the variations that affect patient safety, such as the way teams interact with one another within a context, and the fact that each patient is different. So we don't care for fractured hips and CVAs. Each patient, just as each patient has their own identity, so does each clinical unit. So high reliability recognises that over-standardising can increase risks. So it includes how healthcare workers organise their work, so that they recognise when something is going wrong before it's actually gone wrong. And this is how we hopefully how we designed or like to present the safety fundamentals for teams, as they're not designed to be prescriptive. They are designed to be adaptable, and we're really happy to provide editable resources so that they can be adapted to suit a different context, and I'll talk more about that in a moment. So it says in that paper, organising for high reliability involves attending to not only the culture of a surgical team or a healthcare organisation, their shared values and beliefs, but also to the actual behaviours, practices and interactions that unfold between people as they care for patients and manage the organisation. So as well as looking at the literature, going out to the clinical field, we did look at other forms of data. And I'd like to say from the start that there are a lot of things that are done right in New South Wales Health, and I think that we have provided excellent healthcare from New South Wales, and we didn't need to be told, but I think it's certainly being highlighted right now. We don't always celebrate all the things that we do well, and we sometimes don't have any way of measuring them other than through the reduction in what goes wrong, or so it seems. But when things do go wrong in health, the system failures have really been consistent over the years. So despite the improvements that have been, and there have been many that have been demonstrated in New South Wales Health, the top system factors that are identified through serious incident reviews are always around care planning and communication. And if you look not much further down the list, but very much connected, is teamwork. And we recognise that communication is an international system failure, and is also a problem in industries outside of healthcare. So if we just kind of break that down a little bit in terms of care planning, this is around gaps or failures in collaborative planning where multiple teams are involved, for example, including within and outside of healthcare facilities. So where I worked before as a women's cancer nurse, so I could have been looking after patients who were being cared for by medical oncology, surgical oncology, radiation oncology, and palliative care. And if all of these different teams see a patient at different times of the day, it's very hard for the clinician, let alone the patient, to keep up with what's going on if it's not recorded or it's not communicated. And this is where the gaps are falling. Our communication is both written and verbal, in terms of handover and our communication between shifts, and how we communicate with and include our patients, families and carers in decisions about their care. And this is why we continue to support clinical teams. And I say support and not kind of try and impose onto clinical teams to find better ways of improving communication, teamwork and care coordination. So, and I know and I recognise that most of the feedback from patients is always positive. I mean, we get enough cakes and chocolates to know that. But however, there are occasions when patients feel that they need to complain. And what we're seeing, again, consistently, it's around communication. And if we break that down, it's described as attitudes of healthcare staff, or maybe inadequate information being provided to the patient care of family, and wrong or misleading information. In terms of treatment, it's around the coordination of treatment, and in access, it's around the kind of transfer of care arrangements. If you look over on the Bureau of Health Information's report on the experience, that provide independent reports on the experience of hospital care over a 5-year period, revealed that although there was an increase in positive responses, only 7% of respondents reported their care as being very good. And in that same report, 91% of patients said they wanted to be involved in decisions about their care. However, only 60% of these said that they definitely felt involved. And on how well their care was coordinated, 61% of patients answered very good. So I'm just going to take a pause here and just check in to see if there are any questions or comments before we go into the how. We've just talked about the why and the what. Anything coming up?
Hi, Mary, it's Bernie. Just a question around the availability of these webinars, and Zeb's put up the link for the YouTube channel. But also a question came through when you were talking about psychological safety and staff being able to speak up. The question was, how, though, do we make sure that these changes are safe for staff and they aren't changing something that has been sanctioned by work health safety staff?
That's a good question.
Yeah. It is a good question.
And I think, and I know it's easy to say, and it's something that I reiterate all along, that all of these tools are, all of these resources are meant to help and support team, and they will help and support if they're properly implemented and properly evaluated. And I can speak, I mean, Bernadette, you've just spoken, and I know Bernadette and Debbie Draby and colleagues from the CEC are working on resources around exactly that, speaking up for safety and how to ensure that, how to provide for a safe space for teams.
It's Debbie here. Can you hear me?
Yeah.
Yeah, I was just wondering, there's big emphasis there on communication and also involving the patient, family and care in their care, and yet all the clinical care standards say an individualised care plan. I was just wondering if the CEC is developing some sort of template or standardised format to be able to do this, because this is one area that we haven't been able to address and agree on.
So in terms of a standardised care plan, could you just tell me a little bit more about that?
Yeah, just say, for example, the clinical care standards for stroke, for acute coronary syndrome, for colonoscopy, for delirium. It asks for an individualised care plan that be developed with the patient family carer that we could utilise to give to them on discharge.
Okay.
Yeah, and it's just one thing that no sites have got something that's probably suitable at the moment. So I was just wondering if that's going to be coming from the CEC.
So in terms of, I'm going to call on Brains Trust here, who are working on the comprehensive care standard. Is that something that is being considered, particularly around, I suppose, delirium and?
It's Lorraine. Mary.
Thanks, Lorraine. I'm glad you're there. I can't tell who's there, so thank you.
No, look, it's a very good question, and I think we're going to get lots of them in this regard, because there'd be specific bits of information that from some specialties that would need to go not only through the patient journey while they're in the acute environment, but when they're transitioning from there to wherever, home or rehab or so on. Certainly with the comprehensive care EMR, there's a lot of thought going on at this point through the patient journey whilst they're in acute care, and the sorts of prompts and things that would come up for care planning Specifically in relation to discharge, I don't think we've actually got formally to what that could look like. And I think we're going to have to, at this point, and look, we could have, there are so many clinical pathways. But it's quite problematic. We're trying to look at themes that's common across all, so that you could populate a care plan where you're actually accounting for care that actually is relevant, that might have across a lot of different specialty groups, if that makes sense. So I guess if that was Deb asking that question, it's something I'm happy to raise with the team that we're working with, just to see what that might progress to in terms of her question. Okay.
Thanks, Lorraine. Thanks for that. And thank you for the question. I think I might move on. I will pause again in a little while, but thanks. That's great. Thank you for that conversation. So as I mentioned, we've just talked about the why and the what, and now we'll just explore each of the fundamentals a little bit further. So I know that safety huddles have gained a lot of traction across New South Wales Health, or across everywhere, but speaking specifically from New South Wales, with varying degrees of success. So they're intended to be brief, so less than 10 minutes, and they're definitely worth pursuing through PDSA cycles. So I kind of get on my knees and beg people, just, don't just try once and then throw it out, just give it a go, because they really are evidence-based tools and they're an absolute no-brainer. So like any change, the safety huddles that succeed are those that have had some planning and are consistently adapted. So they're not designed to be a second clinical handover or the time to talk about what has. Rather, it's a time to talk about what is and what could be. So we talk about a 3-point agenda. And so the only time you might talk about what has or look back is really purposefully. So it's to look back on the last shift, or at a maximum the last 24 hours, on what happened in the last 24 hours. Hopefully it's something that you can celebrate and learn from. But if there was an incident or something happened, it's, have we mitigated for that happening again today? Okay, have we put checks in place so that no one trips over that cord, or that medication incident doesn't happen again, for example. So thinking back to the Dirty Dozen talk that we heard yesterday, there was a mention around situational awareness, and safety huddles enhance situational awareness, or that blind spot. So it's the things that we miss when our focus is somewhere else. So it's through that ability to pause, gather information that's viewed through the lens of different perspectives. We've got more chance of picking up cues in the environment and comprehending those cues and projecting on what could happen next. So, for example, you're driving and the car in front of you slowed down to let a family of ducks cross the road, but you're focused on the traffic lights ahead and you can see that they're turning orange. You haven't noticed the brake lights on the car in front, so you put your foot down. But luckily, you've got a passenger in the car who's been watching the ducks in the car in front, and they alert you so that you screech to a stop and no duck was harmed. But you're not relying on your own perspective and not looking beyond what the signs are telling you. So luckily you kind of took on you'd missed those cues that other person who was seeing the situation from a different perspective had, and no harm was caused. So leadership walkarounds, they're starting to take traction, and I know one, especially Network, Justice Health took this on and rolled these out with a lot of planning across their network, and they were evaluated really well. So this is an opportunity for management to hear from the perspectives of staff how things are going, for them to hear how well things are going, or the issues of concern which relate to patient and staff safety. And it can bring the added benefit of immediately resolving concerns, and also shared learning. So this is your problem for you here. Well, I've just been to a unit and this is how they're addressing that, which could be adapted for here. They're meant to be delivered in a positive light and not one where staff feel like they're being checked up on. And to really, for their success, there needs to be a feedback loop which details any follow-up action that has been taken, and whether that's, this is too hard, it's going to take a little while, give us time, or give us a week and we'll do it, or you should see a change in 24 hours. for example, and there is literature associated, emerging literature on what to do and what works and what might not work with leadership walkarounds. And I mentioned the names of all of the fundamentals. I haven't mentioned that earlier. We've named the fundamentals, you know, safety huddles, leadership walkarounds, quality learning boards, and we continue to call them by those names just for consistency from a CEC perspective. But if those names don't gel with your unit or where you work, you can adapt them. That's the sort of, you know, adaptation you can make. You might prefer to call, I know some people during COVID found it uncomfortable referring to huddles. So if you want to call them safety briefings or check-ins, whatever, but from our perspective from the CEC, for the sake of consistency, we use the same terminology. So quality learning boards are around that ability to be transparent. They're an indicator of internal as well as external transparency and are a driver for harm reduction and reliability. So might have mentioned it earlier, that in a culture of safety, transparency is essential. So these boards, they're not the sort of boards that are stuck, you know, behind doors in a back room that contain static material. These are in public places, they're updated regularly, and the design needs to be fairly simple and preferably fits with the unique needs of the team. So these boards were designed by the district out in Western New South Wales local health district. They tested them, developed the prototype, tested them and trialled them, and worked out what areas could stay and what areas could be adaptable so that it fitted in with the different teams. So what worked in a larger district hospital might not have worked as well for the multipurpose services. So there were adaptable areas. And there's areas on there for patient feedback as well, what went well this month. We did have incidents this month, but this is how we're dealing with them. And this is how someone, what some great achievement that someone's made in the last week or so. Did anyone have any comments that you can see, Bernadette or Debbie, Sue? Otherwise, I'll just keep going.
Sorry, Mary, I forgot. I just one question. Zeb's been providing information and links for everyone around all these tools. And as Mary said, they're all available on the website. A question was around safety huddles. Best practice is to have a multidisciplinary team safety huddle. However, if you do not have buy-in, is there evidence that nursing staff huddles are also effective? And are these documented?
Yes. Yeah, I mean, obviously, multidisciplinary team, again, for that range of perspectives is ideal, but any team, any form of communication, if that's fed through to other disciplines and to the patient, yes. There's a lot of evidence around the use of safety huddles by single discipline safety huddles, but yeah, best practice is through a multidisciplinary team approach. So the multidisciplinary team rounds at the bedside is an opportunity really to bring together disciplines and integrate, again, the diverse perspectives that arise from having the mixed skills and knowledge of clinicians and non-clinicians. These include the patient's voice as well for a more comprehensive view, and has the potential to reduce that clinician risk of diagnostic anchoring and bias when there's the ability to cross-check with each other and for the patient to check in as well. There's some shared decision-making, and it's a really good opportunity for developing a transition of care plan, and best done commenced early following the patient's admission to hospital, and that is the ideal. So they're a tool for encouraging open collaborative communication and ensuring that the healthcare team and the patient, their family and care are all working towards a common goal and the same goal. So what matters to you for staff? And I'll certainly be talking a lot more about this when I come up with the COVID resources. And I know I've kind of made a lot of promises about these resources, and there's just a few links to start with, but that is coming, and I think there has been a really a landslide of information and resources to support the need for something that addresses how the staff are feeling and how the opportunity for the staff to be able to bring their whole selves to work. So it's initially it was informed by the work of Helen Sanderson and Associates, and also Dr. Michael West from the NHS, as well as the literature on compassionate healthcare. So it's, as I mentioned earlier, the quality of interprofessional teamwork definitely has a direct correlation on clinician emotional exhaustion. And there is evidence to say that if staff do feel unhappy, staff do feel undervalued, it will be reflected in the care that's provided and has been fed back in a study that is reported in this work here, in more than one study. This is one example. So this slide represents three more fundamentals. So informed by human factors literature, the first one relates to that diagnostic assurance. So it provides practical tools to help clinicians seek further opinions when a patient shows subtle signs of not following the usual path for a diagnosis given. And it's seen in, sorry, somebody's got can someone remember to mute their mic? So it's seen in cases of diagnostic anchoring, and which can have devastating consequences when the next one is commonly performed by nursing staff for a patient, so the intentional patient rounding, where a patient's not left for more than an hour without a review by a clinician. And it's reported to offer reassurance to patients and their families and carers when they know that a clinician is regularly reviewing them and has the potential to prevent harm occurring for changes in patient status to be identified quickly. And the last one, there's a lot of work, and my colleague Debbie Draby is online, who's leading a lot of work around the morbidity and mortality meetings, which is really taking that systems approach and providing a safe space for learning rather than judgment. And these again are a multidisciplinary team participant process for system improvement using data and analytics to help inform discussions. And I think there's going to be later on this year, or in the next couple of months, there'll be a webinar on that when some more resources and tools are released from the statewide advisory group. So how do the fundamentals line up against, the characteristics of high performance? So some of the things that we've talked about today around teamwork and communication, psychological safety, building a safety culture, transparency, leadership. So I started to look at the fundamentals and align them, build a matrix. And I actually could have just put stamps everywhere, but I thought you wouldn't believe me. So I left a few gaps in there. But I think you'll find that they tick a lot of the boxes, and in particular around teamwork and communication. So, safety huddles can promote psychological safety when they're multidisciplinary and have that structure approach. Again, the way leadership walkarounds are approached, and they can take some planning, and they might need to be structured and formal to start with until they develop into a more organic process, like most things. And the quality learning boards are relating to transparency. So just what have we learned now through COVID-19, and what are the additions and adaptations and learnings? So when the pandemic landed in March, in response to the demands placed on the system, some additional resources were added to the safety fundamentals, and the contents for these resources have been sourced from international and national data, as well as drawing on crisis management evidence. So for example, the going home checklist, and in fact, you can see the list there, and I know that Zeb's probably putting the link up there now for you to go and access these resources, which are adaptations of ones that we had and new ones, and also ones that we've borrowed from other places. And it was kind of no surprise, and it wasn't necessarily intentional, that most of the themes for the resources were around attention to staff wellbeing. So with the outbreak of the pandemic, there was a palpable desire for ways to recognise and support staff, particularly those working at the point of patient care. So ways to reassure staff, ways to keep staff not only physically safe, but also psychological safe, and ways to recognise that staff have this extra pressure being placed on them. And so to provide a safe space for them to be able to talk about their concerns. There's a lot of talk around, PPE. Have we got enough? Am I putting it on correctly? When should I use it? How long should I use it for exactly? And it's so important that that environment is set up for staff to feel safe to express those concerns and learn and understand. So again, there've been the theme around the recognition for attention to staff wellbeing and that safe space. So we've witnessed a need across the globe for this strong leadership and direction. And again, this is in line with World Safety Day around health worker safety and protecting our staff. And the NHS has done some evaluations which you can find on the King's Fund website, and some of the findings arising include around the increased use of safety huddles, and they echo a lot of what we witnessed here for teams here, such as, for teams who are reaching for those reliable and tested ways to ensure that communication gets to the right people in a timely way, to provide that space for people to question and to check in. And I know I've worked with teams who were considering safety huddles and thinking about it, and bam, they put them straight in when the pandemic hit, and they're still continuing to adapt and change them, but will not go back. So this was acknowledgement to Bernadette King, who picked this up on Twitter, who found, really great, innovative and creative ways that people are using to ensure that everyone's still involved in communication. So this ED team have moved their handovers outside so that staff can attend in a physically distanced way. And they've also included a pause and a stretch, which I really like. And others, I've asked other teams, well, what have you done? They've moved safety huddles outside the containment of rooms into more open spaces, which they believe has improved their processes. Or, as I mentioned, planned safety huddles have been fast-tracked with positive results. And things that I invite teams to consider now is, what have you dropped? What will you pick back up? And what have you started that you will keep? Other observations are around staff describing feeling valued and supported. The Pandemic Kindness Movement, I hope you've all heard of it, is a clinician-led initiative, and there's some really amazing resources which have been developed or sourced, and they're located on the ACI website. Teams talk about things are happening much faster now. I know from a CEC perspective, we were set up extremely quickly with really good IT systems so that we could function in a business's different sort of way and still provide the support on a needs basis to our clinical colleagues and still be available and connected with the clinicians. So we've developed and are still developing and adapting guidance documents for the fundamentals, and we really welcome any feedback that you've got. If there's anything, I'm really open to constructive feedback. So if you say, look, you've got this, but you haven't got that, how can we adapt this? I've noticed in our team we do this and it works really well, because we take all our learnings from the clinical field around what's working for you and what's not working. And just lastly, before I go, you might be thinking, yep, I want to, I would like to include all of those fundamentals right now, but I can't do that right now because there's too many and it's too much and I've got too much going on. Or maybe you'd like to evaluate ones that you're using already. So we've got, you can see on our website, the Team Stripes framework, which we developed in 2017. And again, this was in response to the evolving nature of our healthcare environment and the requirements of clinical teams. So this framework's informed by a literature review and the key characteristics of clinical microsystems and all the other evidence based on from the teamwork programs. So it's context driven, which is recognising the unique identities of every clinical team with respect to their team culture, their patient cohorts and their geographical setting. So it applies a human-centred design principles and it's a structured, practical approach to support point of care teams. And I emphasise that word support. It's not something that we do to you. It's not something that takes away from what you're doing. It's there to support the work that you're doing and hopefully help prioritise the improvements. So in summary, the safety fundamentals are activities which focus on strengthening behaviours that impact safe and quality care. They really need to be valued. They are important, and when they are implemented and evaluated, staff experience will improve and you'll observe a meaningful impact through evaluation. They're measurable and sustainable. And just before I advertise the next couple of webinars, I wonder if there's any more questions or comments that have happened in the chat.
No, Mary, basically Zeb's been providing links for people around the information. Someone's asked if the slides will be available.
Yep.
Nothing, no other comments or questions on there at the moment.
Great. Okay, so as I said, this is the second in a series of 4 webinars that we're doing this week. So in the words of our Chief Exec, patient safety is about strong leadership and teams that work together. It's also about respectful and compassionate conversation and communication to ensure that we all understand that patient and staff safety is our top priority. It's everyone's business. So there's 2 more really great webinars happening tomorrow, one on the Schwartz rounds and also Living Through the Pandemic, which will be presented by a healthcare associated infection team. If you miss our webinars or can't attend them all, you can catch up on the, which I think Zeb's already put in there, can catch up on our CEC YouTube channel or on the link that Zeb has provided for you. So I really want to thank you for chiming in today and for being a part of the webinar. Thank you for your input and questions. I really welcome any feedback or any suggestions. Would love to learn from you as well in the clinical field about what's working well and what's not working so well. And I hope that you all have a really lovely afternoon and stay safe.